Good afternoon. My name is Sharyn Parks, and I am pleased to have the opportunity to speak with you today regarding the United States Sudden Unexpected Infant Death, or SUID Case Registry and Classification System. I'll also share with you how we've used the classification system to discern, describe, and estimate risk factors for different types of SUID. Before I get into the content, I do want to provide a quick disclaimer that this presentation represents the work of myself and my co-authors and is not an official position of the U.S. Centers for Disease Control and Prevention. Sudden unexpected infant death, or SUID, is a common cause of infant mortality. There are approximately 3,400 sudden unexpected infant deaths in the United States each year. This is defined as the sudden, unexpected death of a baby less than 1 year old in which the cause was not obvious before an investigation. These often occur during sleep or in the baby's sleep area, so are sometimes referred to as sleep-related infant deaths. And this includes those from sudden infant death syndrome, or SIDS, and other undetermined causes, as well as accidental suffocation and strangulation in bed. And though there were declines in the rate of these deaths in the United States following the recommendation to place infants on their backs to sleep in the early 90s, the rate of these tragedies has remained fairly stable since the early 2000s. Differentiating explained SUID from unexplained SUID can be challenging because, again, most of these are occurring during sleep and are often unwitnessed events, which can make determining the exact circumstances and the role of hazards in the sleep environment difficult. To address limitations of traditional vital statistics-based surveillance of SUID, and to help increase our understanding of the true burden and factors associated with sleep-related infant deaths, CDC supports the Sudden Unexpected Infant Death Case Registry, which is a multi-jurisdictional, population-based surveillance system and is built upon the established child death review programs in our participating jurisdictions. The goals of the registry are to conduct population-based surveillance in U.S. states and jurisdictions, to monitor trends and describe the demographic and environmental factors of the deaths, provide information that can help improve death investigations moving forward, and also to ultimately inform prevention activities and reduce infant death rates. Another goal of the registry is to categorize SUID cases using a classification system and standardized algorithm that was developed specifically for the registry. We created the CDC SUID classification algorithm to facilitate consistent and objective evaluation of cases by providing a standardized grouping method to allow for consistent monitoring of SUID, to account for unknown and incomplete investigation information, which can inform improvements to case investigation, and to acknowledge uncertainty about how suffocation or asphyxiation may or may not have contributed to deaths. The SUID classification algorithm also allows for calculation of population-based incidence for each type of SUID based on the standardized grouping, thus allowing for more consistent comparisons of different types of sleep-related infant deaths. It is important to note, however, that the classification system was not intended to reclassify the official cause of death. To illustrate the utility of the classification system, I'd like to share an overview of a paper published in the journal Pediatrics in 2021 called Explaining Sudden Unexpected Infant Death. This study aimed to differentiate unexplained from explained SUID using the SUID case registry. We applied the strict set of criteria from the classification algorithm to over 12,000 registry cases that occurred from 2011 to 2017. We analyzed deaths from 18 SUID case registry states and jurisdictions, and based on review of variables contained in the case registry, trained registry staff classified SUID cases into 6 mutually exclusive categories using CDC's SUID classification algorithm. And the categories were explained suffocation with unsafe sleep factors, Then we had unexplained categories as follows: possible suffocation with unsafe sleep factors, unsafe sleep factors, no unsafe sleep factors, incomplete case information, and no autopsy or death scene investigation. Cases that were classified as explained or possible suffocation with unsafe sleep factors were also assigned one or more mechanisms to which the airway obstruction was attributed, which we'll talk more about in a little bit. So you can see that the age at death in months follows what we typically see for sudden unexpected infant deaths. And 90% of these deaths occurred during the first 6 months after birth, with a peak between 2 to 4 months of age. As is typical for SIDS and SUID, that was more common among males, with 58% of deaths occurring among male infants. And when we compare our registry cases to the birth population among participating jurisdictions, we found that non-Hispanic Black and American Indian Alaska Native infants are overrepresented among the SUID cases. For instance, non-Hispanic Black infants represented 16% of the birth population in the 18 states and jurisdictions in our data, but 36% of the SUID from those jurisdictions were Black. When we consider all of the cases together, unsafe sleeping circumstances were all too common. Overall, we found that 72% of SUID occurred in unsafe sleeping circumstances. We found that cases classified as unexplained, unsafe sleep factors constituted the largest proportion, so 40% of the unexplained categories. These were deaths where there were known unsafe factors in the environment, but that for which we don't have evidence of anything having obstructed the infant's airway. Thus, the cause of death remains unexplained. Less than 1 in 5, so 18% of SUID were explained as suffocation deaths. Although these explained deaths constitute a small proportion of SUID, these deaths are nearly always preventable. And about 1 in 8 were classified as possible suffocation. And these deaths may also largely be preventable. Among the explained and possible suffocations, the majority, so about 3/4, were attributed to soft bedding, having occluded the infant's airway. The second highest proportion of cases were those 27% that were classified as incomplete information. This group is a combination of two algorithm categories. Incomplete case information, which consists of cases where there wasn't enough information documented from the investigation to tell where and how the baby was found. And the second category is those cases that were missing a death investigation and or an autopsy altogether. So what's the significance of these findings? Explaining how and why SUID occur is critical to understanding the etiology and reducing the risk of future infant deaths. Unsafe sleep circumstances were common among SUID cases, but the data that were available to us could only explain why the death occurred in about 1 in 5 cases, so those that were classified as explained suffocation. Understanding the mechanisms that contribute to suffocation deaths and the frequency at which they occur is critical in forming effective prevention strategies as well. We also conclude from the findings in the study that more thorough investigations and autopsies can help determine the role of intrinsic factors such as cardiac channelopathies, genetic abnormalities, or even seizure disorders, and or extrinsic factors like prone sleeping position, soft bedding, or shared sleep surface in causing infant deaths. It's also important for us to consider how social determinants of health impact access to or receipt of screening for intrinsic factors and the ability of families to adhere to extrinsic preventive factors. So the need to collect data that can help elucidate that is critical. Our other takeaway from this study is that our classification appears to do what we had hoped. It allowed for consistent objective classification, and it also improves the consistency of our surveillance and our understanding of epidemiologic trends in SUID. There were some limitations to our study to mention. Classification depends on the accuracy and completeness of information collected. For instance, all information from medical legal reports may not be captured in the registry. Also, investigation is frequently complicated because most SUID, again, are unwitnessed events, and evidence can be compromised during resuscitation or transport. And then technical assistance and resulting improvement in data quality associated with participation in our case registry limits the generalizability of our findings beyond the states and jurisdictions that participate. Also, participation in the registry varied over time, which limited our ability to examine trends. So what are the suggested actions aside from continued use of the classification system to understand and improve data? First, we know that more than 70% of cases were found in an unsafe sleeping environment. Thus, safe sleep recommendations were not being followed. We need to improve our understanding of the reasons for non-adherence to the recommendations, like lack of knowledge or financial barriers, and then identify methods to address these factors. We're also increasingly realizing the importance of exploring social determinants of health and how they impact families' access to and receipt of screening for intrinsic factors, as well as their ability to adhere to extrinsic factors, which may increase risk for sleep-related death. Second, we've come a long way with regard to infant autopsy and death scene investigation and documentation, but continued improvements are critical to further improving our understanding of sleep environments' role in infant deaths. This can be achieved by addressing some of the training and resource needs that have been identified within the medical legal death investigation community. And thirdly, we noted that 18% of cases in this study reported recent illness and or injury. So these are infants who may have had recent contact with a health provider, potentially representing additional opportunities for receipt or reinforcement of safe sleep messaging. Thus, it's really important that every infant encounter be viewed as an opportunity to teach and re-emphasize the safe sleep basics. Next, I'd like to talk a bit about the next paper we worked on. So once we had a good sense of the applicability of the classification system over time and a detailed characterization of how SUID were grouped into categories and mechanisms, our next undertaking was to look really closely at the group of SUID which were explained suffocation, because this is the segment for which we are confident in the cause of death. And we view this group as the most urgent to address in terms of prevention. Thus, we undertook a study to examine risk factors for this group alongside those for unexplained SUID. So this study, entitled Risk Factors for Suffocation and Unexplained Causes of Infant Death, was published this past January in Pediatrics. We again used the CDC SUID classification system to identify SUID that were either due to sleep-related suffocation or unexplained causes. And then we examined risk factors for sleep-related suffocation and unexplained infant deaths independently of one another. To accomplish this, we conducted a population-based case control study using infants born during 2016 and 2017. The cases, again, were from the case registry, and then we had live-born infant controls from CDC's Pregnancy Risk Assessment Monitoring System, also known as PRAMS. The study population consisted of infants who resided in Alaska, Delaware, Louisiana, Michigan, New Jersey, New Mexico, and Wisconsin, which are states participating in both the SUID Case Registry and PRAMS. PRAMS provides a representative sample of live-born infants from the participating states and jurisdictions. The control group in a case control study is selected to provide information on the exposure distribution in the population that gave rise to the cases. The comparison group or control should be representative of the source population that produced the cases. The source population is the population that gives rise to the cases included in the study. So by using PRAMS, we had a representative sample of live births. The live births were the at-risk population for SUID. In this case control study, it's important for the controls to be sampled in a way that is independent of the exposure, meaning that the selection should not be more or less likely if they have the exposure of interest. We created a state representative pseudo-population of controls to represent all registered live births in each of the included states. To do this, we duplicated each PRAMS record by its corresponding PRAMS person weight. Then, from the pseudo-population of over 600,000 live births, we randomly selected 4 living controls for each case. Controls were then matched to cases on infant age, so age at death for cases, age at the time of survey completion for controls. We calculated prevalence for 5 primary exposures, being sleep position not on back, soft bedding use, sleep surface type other than a crib or bassinet, sleep surface sharing, and not sharing a room with a caregiver during sleep. We estimated risk by calculating exposure odds ratios for both outcomes, so that's suffocation and unexplained death, after controlling for potential confounders. The confounders that we included were those that were previously identified as risk factors for SIDS, including the demographic and maternal variables shown here. We found that after adjustment for the demographic and maternal factors, the magnitudes of risk for suffocation and unexplained deaths differed. Non-supine sleep was associated with 1.9 times the risk of suffocation and 1.6 times the risk of unexplained death. Soft bedding use was associated with 16 times the risk of suffocation and 5 times the risk of unexplained death. We had a fairly large confidence interval for the estimate of suffocation risk, and it did overlap with the confidence interval for unexplained death. Infant sleep location on a non-approved surface, something other than a crib or bassinet, was associated with 4 times the risk of suffocation, but no increased risk of unexplained death. Again, note the confidence interval for risk of unexplained death crossed 1, so this wasn't statistically different. The infant sleep area not being in the same room as a caregiver was associated with 19 times the risk of suffocation and 8 times the risk of unexplained death. Here again, we had a pretty wide confidence interval around the point estimate for suffocation risk that overlapped with the estimate for unexplained death, meaning you cannot rule out the possibility of the point estimates being the same. But the important piece here is that there's a huge increase in risk of dying. Infant sharing a sleep surface was associated with 3 times the risk of suffocation and 2 times the risk of unexplained death. Here again, the confidence intervals around the point estimates for suffocation and unexplained death overlapped, meaning you cannot rule out the possibility of the point estimates being the same. So to summarize all of these findings, the magnitude of risk associated with sleep environment factors were generally larger for suffocation. The magnitude of risk associated with soft bedding and not room sharing were more than twice as large as the risk for unexplained death. The confidence intervals for the estimates of suffocation risk associated with both soft bedding, and room sharing were pretty large, likely due to the smaller cell size for the suffocation group as compared to the unexplained death group. But the large difference suggests a likely clinically meaningful difference that warrants further examination. Non-approved sleep surface was associated with suffocation, but not unexplained death. Not room sharing was shown to be a risk factor for both suffocation and unexplained death. These findings were unique because prior studies, including prior case control studies, have not examined risks associated with suffocation separately from unexplained death. There were some limitations to this study as well that I'd like to mention. There was the potential for social desirability and non-response bias in reporting sleep practices for cases and controls. Because most SUID deaths are unwitnessed, as I've mentioned several times, there are limitations in how much data on the circumstances of death are missing. And finally, the results may only be generalizable to the 7 case registry and PRAM states included in the study. To put this information into practice and incorporate into safe sleep education, consider that the risk for sleep-related suffocation may be a concept that's easier for parents and other caregivers to understand than risk due to unknown causes. Also, risk factors are not created equal. It's important to ensure that SIDS education and safe sleep promotion programs address the riskiest factors. So from our study, we see that those highest risk factors were soft bedding and non-room sharing. I'd like to conclude, as I do every presentation, by re-emphasizing the safe sleep basics, so ensuring baby's in a crib on his or her back with no soft bedding, and have baby share your room but not your bed. I'd also like to thank all of our partners shown on this slide, and thank you again for the invitation to speak with you today and for your time.
Q&A session.